Good afternoon, everyone. This is Trip Vanderwall, member of Miller Johnson's Employee Benefits and Executive Compensation Practice Group. Welcome to our first benefits lunch break webinar of 2022. Thank you for all of those that are returning to these webinars and participated in 2021. Due to your input in November and December last year, we have decided to continue this webinar into 2022 on a monthly basis. So just like last year, we will have a monthly webinar on the third Wednesday of each month at 12 p.m. Eastern Time. Now, the one difference is in 2021, I was kind of the host of these webinars, so I was on every single one of them. I did bring some guests, as you likely are aware, to help me present or even to take the majority of the presentation. But going forward this year, we're going to kind of divide up these webinars amongst our group a little bit more. So I may not be on the webinar. I'm sure that there's a collective sigh of relief from everyone. I will not be on there every month. In fact, I believe in February, our webinar will be hosted by my partners, Jim Brunsma and Jeff Gray, and they, I believe, are planning some 401k basics, if you will. Again, we will try to get a title and description of the webinar out to you guys at least a week early to make sure that if it's something that you are interested in, that you can sign up and attend. And as always, these webinars are recorded. They are made available on the firm's YouTube page shortly after we end. And if you would like a copy of the slides, feel free to contact us and we can get you a copy. With that said, we do have some of the webinar subjects for 2022 planned out already this year, but we are looking for input just like last year. So in the question and answer feature or in the post-webinar survey, if there's a specific subject, a benefit subject at least, that you'd like us to potentially look at, feel free to let us know, and we'll see if we can, if we can fit that in. Moving right along here, let's get started with today's webinar. So today we're going to talk about the various transparency provisions under the Consolidated Appropriations Act 2021. The Consolidated Appropriations Act is actually a $2.3 trillion bill that combined $900 billion in stimulus relief for COVID-19 and $1.4 trillion in omnibus spending for the 2021 fiscal year. This bill was actually signed, I'm sorry, there's a mistake on that slide. It was signed on December 27, 2020. By President Trump. December 27, 2021, President Trump was no longer president, so I apologize. So it was signed over a year old. And frankly, as I kind of perused this bill, or at least the table of contents, the Sunday evening that it was signed back in December of 2020, I started to realize that this bill probably had the most significant impact on employer-sponsored group health plans since the passage of the ACA back in 2010. And frankly, many of these changes were set to take effect for the first plan year that begins on or after January 1, 2022. But fortunately, as we'll discuss as we go through this presentation, the DOL delayed some of these effective dates. So, really, without some of the delays, if you have a calendar year plan year, your plan is subject to a lot of these transparency provisions, effective as of January 1 this year. Again, some of these provisions have been delayed. Now, I think the one overarching or through line here is, while most of these, if not all of these requirements do apply directly to group health plans, I think that you'll pick up fairly easily that for fully insured health plans, it's going to be your health insurer, your health insurance carrier that is obligated to make sure that your plan is compliant. And because the federal government, the Department of Labor, IRS, CMS, HHS, they have jurisdiction over insured health plans in conjunction with state departments of insurance, fully insured health plans, the insurers, somewhat on the hook to make sure that the plans that they insure are compliant. Now, if you have a self-funded health plan, I think ultimately it's going to be your TPA that has to administer the plan in compliance with these requirements, because frankly, employers are not, employers are in the business of doing what they do, not necessarily administering health plans, and so therefore aren't going to be able to do this. Now, to the extent that the TPA fails to administer a health plan in compliance with one of these requirements, then it's going to be the group health plan or the plan sponsor that's ultimately liable for any penalties or financial repercussions that occur from the failure to satisfy these requirements. So what you may want to do as you're reviewing your TPA agreements is make sure there is some indemnification language in there that maybe if you as the plan sponsor are punished or held financially liable for some failures, that maybe you can seek relief from the TPA to the extent that they were that the error or failure was their fault. So as indicated in the title, we're going to take a fairly high-level review of the various transparency requirements under the CAA. But keep in mind that in 2021, we did a number of deep dives into some of the transparency provisions. And so we're not going to touch on those today. And specifically, in February of 2021, and these were all in the monthly lunch break series, so they're all still on the firm's YouTube page. We looked at the Mental Health Parity and Addiction Equity Act comparative analysis requirement. So that was February of last year. In August and September, we did a two-part series webinar on the No Surprises Act. And then in November of last year, we did a webinar on the broker and consultant compensation disclosure requirements. So keep in mind that those are also requirements under the CAA, but because we did a fairly robust in-depth dive on those issues, we will not be covering them today. With that overview accomplished, let's get started. So the first one is these cost transparency tools. So group health plans under the CAA are generally required to make price comparison information available to participants through two mechanisms, either a telephone or an internet website, which virtually allows the participant to compare cost sharing information with respect to items or services covered under the group health plan. So let's say I'm needed some a procedure to my knee. It's not urgent. It's not it's something that I'm going to schedule. And basically, this cost transparency tool should allow me to go in and input some information about the procedure that I need. And in response to that input, it will kick out either through the internet or through the telephone what I should expect my cost sharing to be should I have this procedure at such and such provider. Now, what's coincidental about the CAA requirement is before the CAA was passed, the Departments of Labor, Health and Human Services, and IRS issued regulations that were almost duplicative of the CAA requirement. In those regulations, non-grandfathered group health plans, and let me take a step back here. The CAA cost transparency tool requirements apply to all group health plans, grandfathered and non-grandfathered. In fact, unlike the ACA, which had protections for grandfathered plans, the CAA does not have those same protections. So CAA requirements, there's no distinction between a grandfathered and a non-grandfathered plan for purposes of requirements that fall under the CAA. So again, these departments issued regulations before the CAA that required non-grandfathered group health plans to disclose cost information upon request for certain covered items and services. Excuse me. For those items, under those regulations, for plan years beginning on or after January 1, 2023, so next year, this cost transparency regulations applied to 500 items or services that were identified in the regulations. And then the next plan years beginning the next year on or after January 1, 2024, the requirement applied to all covered services under the group health plan. Under the in additional, these regulations had an additional requirement in addition to, to this cost transparency, and that non-grandfather group health plans were required to disclose on a public website the following information in what they call machine readable files. And these were three separate machine readable files. And it was in-network provider rates for items and services that were covered under the health plan, the out-of-network allowed amounts and billed charges for covered items under the services. And I think that was kind of on a rolling 90-day basis. And then third, negotiated rates and historical net prices for covered prescription drugs. And I think the idea is by publishing these in these machine readable files, and a tech person I am not, on a public website, is you'd encourage different vendors out there to start gobbling up this information or accumulating this information and processing it in a way where, whether they sell their services or make these services free to the public, individuals can go out to these third-party websites and look and try to compare. Okay, where are we seeing these rates? Where are providers maybe? What providers are we seeing lesser rates at? Again, with the overall effort of increasing transparency. So the departments realized that there was a lot of overlapping requirements under this cost transparency tool required by the CAA and the cost transparency requirements under the regulations that they issued. So what they did is they basically said, hey, the CAA cost transparency tool was supposed to be effective for planned years beginning on or after January 1, 2022. We're going to kick that out of you. So we're going to use our discretion to not enforce, to take a non-enforcement policy with respect to the CAA requirement, at least until January 1, 2023. And I think the idea is that the departments will reissue their previous regulations and try to make compliance more uniform, right? So if a health plan complies with the requirements under its regulations, it's arguably also going to apply it with the requirements under the CAA. There's not going to be duplicative, separate but duplicative requirements, if you will. With respect to the machine readable files that have to be published, they also took enforcement discretion and said, hey, we're going to delay that for 6 months. So at least with respect for the in-network provider rates and the out-of-network allowed and billed amounts, which were the first two elements on the previous slide, we're gonna delay that until July 1, 2022. And with respect to the prescription drug information in a machine readable file, we're going to delay that until we have time to issue further regulations. Now, with respect to the delay till July 1, 2022, for the network provider rates and out-of-network allowed and billed amounts, keep in mind that this is going to be somewhat of a retroactive requirement if your plan year began on or after or on or before July 1. So let me give you a couple examples here. Let's say my plan year is a calendar year plan, begins January 1. I don't have a requirement. My plan doesn't have a requirement to publish this information until July 1 of 2022. But when that requirement kicks in on July 1, I have to publish this information going back to January 1 of 2022. So for that first 6 months. So it's more of a delayed effective date than it is just a non-enforcement safe harbor. Now, for example, if you have a plan year that starts September 1, 2022, this delay doesn't really impact you because you weren't subject to it until September 1. But when your requirement to report this information or publish this information on public websites kicks in on September 1, 2022, you just have that obligation to publish the information from September 1 going forward. No requirement to look back and publish that historical information. We got a question that says under a plan that the only cost sharing the participants have is a deductible. So how does it benefit to know that there's $500 charge for something when the only charge is going to be a small copay? Well, I'm not sure I totally understand the question because they have a copay and a deductible, so that's not the only cost sharing, and those can operate interdependently. But I think the idea would be to say, hey, if I go to this provider, here's what my copay is going to be, and then here's how it's going to apply. Like, and it's going to show me, have I hit my deductible? So is it still going to apply? Have I hit my out-of-pocket maximum? So I think even in that question, it is going to be relevant, and it's going to, and arguably it's going to show if I put in different providers where potentially I, as a participant, am going to pay less. Maybe it's just an in-network, out-of-network thing. maybe there's other providers that charge less. So again, I think, the fact that you only have quote unquote a deductible is not going to get you out of this requirement. I think it is going to potentially be beneficial to your, this cost transparency tool is going to be beneficial to your participants. Moving along, advanced EOB. So EOB is an explanation of benefits, and you folks on the webinar are probably familiar with EOBs, but typically you get them after you get a service, right? So you go to the doctor's office, for whatever reason, maybe you pay your cost sharing, your copay, or when you show up there, and after it's done, a few days, maybe a few weeks later, you get from your insurance company or your third-party administrator an envelope, and it's an explanation of benefits, and it basically says, here are the services that were provided at your last visit. Here's what was billed by the provider. Here's what the discount is that we've negotiated. Here's what the plan paid, and then if you have any excess, here's what you owe. And of course, it will say this is not a bill, but you should expect to get a bill from the provider directly. And you may want to make sure that the amounts in the EOB are consistent with the amount on the provider bill. Well, really, all this requirement is potentially to give these EOBs in advance of the service. So I go in to maybe scheduled procedures with my eyes wide open about what I potentially am going to have to pay out of pocket that my health plan is not going to pay, and considering all kinds of factors, in-network provider discounts, whether I'm seeing an out-of-network provider, all that. And so you can see, group health plans have to provide an advanced EOB to participants and beneficiaries, either through the mail or electronically. And it includes various information that we would expect to see on a traditional EOB. These EOBs have to be processed by the following deadlines. It's within 1 business day after receiving a good faith estimate from a provider or a participant request. And really so the advanced EOB is going to be triggered one of 2 ways. It's either I go to a provider and my provider is supposed to ask me if I have health plan coverage. And if I indicate that I do, and I'm trying to schedule a procedure and I ask for a good faith estimate from the provider is supposed to send that to my health plan. And in my health plan, when they get that within 1 business day, it's supposed to kick out one of these advanced EOBs that factors in, the good faith estimate, how that's going to apply to the accumulators, my deductible, my out-of-pocket maximum, and whatnot. And I'm supposed to get that advanced EOB within 1 day. Now, there's an exception to that if basically I'm, the good faith estimate. I'm sorry, and I can also get an advanced EOB if I go right to my health plan and request that advanced EOB. Excuse me. So this 1-day deadline is delayed to 3 business days from the date of receiving the good faith estimate or the participant request if the service is scheduled at least 10 business days in advance. So let's say I'm scheduling a knee surgery, sometime in February, right? Well, then I talk to my provider and say, I'm covered by such and such health plan. Can you give me a good faith estimate? Provider turns around and gives me the good faith estimate, sends it to my health plan. In that situation, the health plan only has to send me the advanced EOB within 3 business days. Now, key here is the advanced EOB and the requirement for providers to provide good faith estimates to a group health plan was delayed. So again, it was originally supposed to take effect for plan years beginning on or after January 1, 2022, but that has been delayed until the departments can issue additional regulations. So who knows when that will be? I expect when those regulations are issued, there will be it will probably come out in some preliminary regulations that are not applicable. They'll have some notice and comment period. Then we'll get final regulations, and then there will likely be some prospective effective date. So, just to make you aware of these, this is not something that is kicking in right now, but is coming down the pike. I've got a question about billed amounts. I'm not exactly sure. Billed amounts. I think this goes back to the cost transparency tool. Billed amounts would be amounts that I think we need to look. We'll have to look for additional regulations on this. But billed charges, I think, would be amount charged by the health plan before any negotiated, or I'm sorry, amounts charged to the health plan by the provider. So basically the provider's listed rates before what not necessarily what the plan paid, because what the plan paid would be set forth in the out of network allowed amounts, where the billed charges would be what was charged by the participant. Sorry to go backwards there. We're going to catch up here. So again, advanced EOBs, moving on to the next subject. And this is reporting of prescription drug costs. So effective January 27, 2021, and I know that sounds like a weird date, but December 27, 2020 was the date that the CAA was signed by President Trump. So basically gave a 1-year effective date. And every June thereafter, group health plans must report certain information to the federal government with respect to its prescription drug coverage. And there's a whole slew of elements that have to be reported. And I will tell you, they're all on the slides here. I don't need to read them all to you. You can read them through yourself. But just note that while it is kind of focused on prescription drugs, there is information that I would say is not prescription drug information that also has to be collected. Case in point, total medical and RX spend broken down into various categories, including hospital costs, professional costs for primary care and specialists, prescription drug, and other medical costs. So obviously there's some reporting elements in that are not just necessarily related to prescription drugs. This requirement, again, we've already passed kind of the first due date, which was December 27 of last year. The Department of Labor issued guidance that delayed this requirement, but did encourage plans to work toward reporting, in 2022, recording required information for 2021 and 2022 by the end of this year. In the fall of last year, in the fall of 2021, the departments did issue regulations on these reporting requirements, and then even more recently issued some sample, there's a correction, they didn't issue a sample reporting form yet, but they did release sample reporting instructions. So those are available online. If you have questions about those, we can help get those to you. Now, the preliminary regulations issued by the departments indicate that that TPAs are going to be able to report this information on behalf of the group health plans that they administer. And it also anticipates that these TPAs will be able to report this on an aggregated basis, so they won't necessarily have to report this information for each separate plan that they administer. They can aggregate all this information for all the plans, at least within the same markets, whether it be a large group self-funded, a small group self-funded, large group fully insured, small group fully insured. They'll be able to aggregate all the plans that they either administer or they insure in those markets and report this information on an aggregated basis. So again, I think that the brunt of this requirement is going to be borne by either your insurer of a fully insured plan or a TPA if you're a self-funded plan, but wouldn't necessarily hurt at some point during 2022 connecting with your insurer or TPA to make sure that it's prepping for these reporting requirements. Prohibition on gag clauses. So I think a gag clause is basically a contractual provision that prevents someone from giving a participant certain information that may otherwise be relevant. And I think maybe this transparency provision may not directly go to this issue. I think probably the best example of this is, we've all heard about this. You go to fill a prescription drug, you present your health plan card, and the pharmacy charges you whatever your applicable copay or coinsurance is. And the pharmacist or the pharmacy was basically prohibited through its agreement with a PPM or whatnot from telling you that actually, if you would have just purchased that health plan without the benefit of your health insurance, that the cost would have been cheaper. So that's kind of what a gag clause is. And so effective December 27, 2020, which is the date that the CAA was signed. So this requirement was basically effective immediately. Group health plans are prohibited from entering into these agreements with providers, network associations of providers, TPAs, or any other service provider that offers access to a network that prohibits these types of gag clauses. And again, I think if you're an employer on the line with a health plan, you're like, well, I don't really have any of these agreements. You're probably right. The only one you typically have is maybe a contract of insurance or a policy with a fully insured, with a carrier for a fully insured plan, or administrative services agreement with a TPA for a self-funded plan. You're going to want to make sure that you review those agreements and that they don't have any gag clauses, and possibly that there's an attestation or a requirement on the TPA or the other party that they will not enter in any of these agreements on behalf of the plan that have these gag clauses. So again, more specifically, it prevents the providing provider-specific cost or quality information data that complies with HIPAA rules to referring providers, to the plan sponsor, and participants. And for this purpose, the term participants includes employees who are eligible to participate in the plan but may have waived. So it'll be interesting to see how that works. And again, the sharing of this information all has to be consistent and applicable with the HIPAA privacy rule. So it will likely have to be de-identified. So interestingly enough, the departments don't think that this requirement is self-implementing. And by that, I mean, they think that they don't have to issue additional regulations. People will just understand it. However, they did say until that they do issue further guidance. So if they do, group health plans are expected to implement this prohibition on gag clauses using a good faith, reasonable interpretation of the statute. And while it doesn't necessarily say it in black and white here, the way I anticipate this is the department's enforcement policy is hopefully going to be more one towards encouraging compliance versus penalizing non-compliance. So if you have a Department of Labor audit of your health plan and they find that maybe you have some agreements that violated this requirement, the department will help you come into compliance with this requirement rather than smack your hand with a ruler for not complying. The other interesting part is apparently group health plans are going to have to provide attestations to the government that they do comply with this requirement. It is completely unclear at this point how a plan is going to do that. However, the department's indicated in FAQs that during 2022, they do plan to issue some guidance to explain how plans can submit this attestation. Maybe, I have no idea, but maybe it's simple as they'll add a question on the form 5500, for example, such as, do you certify your health plan does not enter any agreements with, that prohibits, that has these gag clauses in it. Maybe that works, maybe it doesn't, because, as many of you know, smaller health plans with less than 100 participants aren't required to file 5500s, and they're arguably not exempt from this requirement. So how this is going to be done remains to be seen. I'm very curious about it, but when we know more, we will certainly update you. All right, additional information that has to be contained on health insurance cards. So really we have the additional information is any applicable deductible under the plan. And some, so if you have different deductibles for in-network and out-of-network, those are going to have to be put. If you got, some plans have three tiers of network. They have like kind of a internal in-network, a greater in-network, and then an out-of-network. Arguably all three of those deductibles. And if they're all three of those tiers have different out-of-pocket maximums, those all have to be included on the insurance card. My understanding is the industry used to contain a lot of this information on insurance cards, but they moved away from it because arguably these amounts would change every year and we'd have to be issuing new insurance cards, ID cards every year, just for purposes of updating this information. So a lot of cards deleted that information. Well, it's coming back. The third element is a telephone and number and internet address where consumer assistance and provider network information can be obtained. Now, I've worked with some people who have expressed some concerns about this and said, listen, we already got a lot of information on our health insurance ID card. And frankly, we don't have the real estate to put all this information on. What are we to do? Well, the department's issued, again, in the form of FAQ, some guidance that said, hey, maybe you can use a website or a QR code. So we'll put as much information that we can put on there, the most relevant. And then we put a QR code where somebody can scan it with their phone. It takes them right to a web page that contains all of this other information. At least in the interim, that appears that method is blessed by the Department of Labor. And I find that interesting because QR codes is not something that I really even thought about or used much prior to the COVID pandemic. But as many of you are aware, it seems to be today. If things are relaxing, but you go to a restaurant, they don't give you a menu anymore. There's a QR code, on the table. You scan it with your phone, and up comes the menu. So I'm a little bit curious if that, the fact that these have become more used in everyday life is kind of what drove the departments to allow this. So the DOL plans to issue additional regulations around this requirement, but not before the effective date, which again is for plan years beginning on or after January 1, 2022. This effective date was not delayed, but again, this enforcement safe harbor seems to apply in that the DOL expects compliance using a good faith, reasonable interpretation of the law or the statute under the CAA. We're getting close to the end here, so bear with me. Now we're moving on to the accuracy of provider directories. And so again, effective for January 1, plan years beginning on or after January 1, 2022, this effective date was not delayed. Plans must establish a process to update and verify the accuracy of a network provider directory information, whether that be maintained through a telephone or on the internet or either one. They also have to establish a protocol for responding to requests about network status from a telephone and electronic communication from participants. And what's interesting is they have to respond the way the participant wants. So if the participant wants to respond electronically, they can get it. They get it electronically. If the participant wants a response, for example, by paper, then it has to be mailed. So, for example, let's say I call, my health plan or whoever's administering my health plan and say, is, provider XYZ in network. Obviously they can tell you right over the phone, but they're going to have to ask you, how do you want us to follow up? You want us to, electronic communication, whether that be an email or whether we post that kind of on the individual's portal. A lot of times insurers and TPAs maintain a website that you can log in and see, your deductible accumulators. Do you want it to go into that message status, or do you want us to confirm it by mail? Again, there's not going to be regulations issued about this requirement before it's effective, because it's virtually effective now for calendar year plans. But there's this good faith, reasonable compliance requirement. And the department's also said, we will deem you in compliance that basically, and this is a requirement that is going to go on, that if a participant has provided incorrect information from when calling a provider directory, you basically have to process the claim as though it was the service was provided by an in-network provider. So I call my health plan and I say, is provider XYZ in my network? They say yes. I go get a item or service from provider XYZ. All of a sudden it's determined that that provider is not in fact in my network. Maybe they had recently dropped out, or for some reason they were never in it. Then the plan has to process my claim, using in-network cost-sharing amounts, and my cost-sharing that I do have to pay has to be attributed to my in-network deductible and in-network out-of-pocket maximum. Air ambulance reporting. So fortunately, this is another federal reporting requirement. Fortunately, it's only going to apply for 2 years, calendar years 2022 and 2023. And again, I think it's most likely that TPAs and health insurers are going to report on behalf of their group health plans. But you can see all of the information that has to be reported about air ambulance services. And states have tried to learn more about pricing of air ambulance services, but because of a federal law that governs air traffic, a lot of air ambulance providers have refused to provide that and said, well, this federal law preempts you. We don't have to provide it. So it's much like ERISA preempts state insurance laws in certain situations. There's this federal aviation law, I cannot tell you what it is off the top of my head, that basically made it hard for states to regulate air ambulance service providers. So the federal government is stepping in, and they're trying to, through this 2-year reporting requirement, ascertain more information about the cost of air ambulance services, whether that be fixed wing, airplane, or rotary, a helicopter. And so you can see all the information that has to be reported there, and goes on. So again, group health plans may contract with their insurer. I think fully insured plans arguably have a legal obligation under this requirement to report on behalf of group health plans that they administered. TPAs can do this, but again, if a TPA falls down, and misses this requirement, any financial liability from that failure is going to be imposed by the government on the group health plan and therefore the plan sponsor. So really the only way to legally shift this financial obligation to the TPA, if it is their fault, is contractually through an indemnification, for example. Finally, the due dates for this reporting requirement is March 31 of the year following, and the reporting year is actually the calendar year. It's not the plan year. So again, for this information that is, these claims information, ailments, claims information that occur in 2022, the deadline to report this information will be March 31 of 2023. We do have regulations on this, but I expect that we will get final regulations and probably additional instructions and/or reporting forms at some point in 2022 to determine more information about how exactly we're going to do this reporting requirement. Finally, moving on to our last subject of today's discussion is this continuity of care. Again, this is a requirement that applies for plan years beginning on or after January 2022. It is not delayed, but again, the good faith reasonable interpretation is going to apply. But essentially, that group health plan must provide a notice and transitional care for a continuing care patient for up to 90 days in situations where that continuing care patient is receiving care from a provider or at a facility that leaves the plan's network for reasons other than quality concerns or fraud. So let's say I have, I'm had a non-elective surgery. I am at a facility where I am, recuperating from that surgery, and for some reason that facility, while I'm there, leaves my health plan's network. Well, in that situation, my plan will basically have to notify me that I have this opportunity to elect transitional care. And if I so elect that, then for a period of 90 days or shorter, the date that I'm no longer a continuing care patient, the plan will have to pay that facility as though it's still in network. And there's a corresponding requirement under the Public Health Services Act that the provider or facility will have to accept that as payment in full, as if they were still in the network. So again, no regulations have been issued yet, but a good faith, reasonable interpretation of the statute will apply until that guidance is issued. And again, the continuing care patient is defined, so it's not just someone that's in non-elective care. It's someone that's being treated for terminal illness if they've been diagnosed as terminal ill. It's someone who's pregnant, who's receiving care for the pregnancy. It's someone that's receiving care for a serious, complex condition, which is also a defined term. So you can kind of go through rabbit hole by rabbit hole. But this is, again, from a high level review, this is a requirement that now applies in the event that I'm receiving care from a provider or facility that leaves my plan's network in the middle of providing that care. Again, I want to thank everyone for joining us. Make sure you join us again in February, which just to give you a quick reminder, that date is February 16th will be our next employee benefit monthly lunch break series. Thanks again, everyone, and have a great month.